Hello, everyone, and welcome to another edition of Fit RX. I'm your host, Dr. Greg Dennis. I always enjoy having other physicians um, on the podcast here, and especially ones that are way smarter than me, like a vascular surgeon. That's who I have today. Dr. Lily Johnston is my guest, and I found her by watching some videos for some CMEs I was recently doing at a for a low carb conference that was recorded back in January, and she was a guest lecturer there. And as I mentioned, she's a vascular surgeon, but also talked a lot about just metabolic health, which they do at these conferences, and so that just really kind of piqued my interest. And fortunately, I was able to get her on the show, and I'll just kind of pick her brain a little bit about metabolic health and cardiovascular disease, and maybe how we can best prevent it. And so she is a surgeon at Scripps Memorial Hospital. She also has kind of a metabolic wellness type practice that she does at Nexus Health Span. And I'll give you that information towards the end of the show. So, Dr. Johnson, welcome to the show.
Thanks, Dr. Dennis. Great to be here.
Yeah. Well, as I kind of mentioned, I always like, kind of like-minded physicians, but I find that that's kind of rare, especially as it pertains to specialists. I feel like, I mean, specialists certainly have their place in medicine, but I feel like they're just, so laser focused on what they do, they sometimes fail to see the big picture, such as like the importance of metabolic health and things like that in the prevention of diseases. And so, tell us, I guess, your story. Like, how did you come to, I guess, recognize the importance of metabolic health and kind of incorporate that into your practice as a surgeon?
Of course. And I think, like most people in this space, it starts with a personal journey. I was in vascular surgery fellowship. I was suffering through a my first Minnesota winter. I was far from home, far from family, and it was really challenging and hard. And I started, using food as a coping mechanism, and found myself 6 months into fellowship, home for the holiday vacation with my family, thinking, "Gosh, I am not my best self. I am feeling stressed and anxious and a little depressed, and I'm eating too much sugar, and I'm probably drinking too much wine. And like, this isn't a great long term trajectory for me. Nothing was catastrophically wrong, but I was certainly heading in a concerning direction. And coincidentally, my mom happened to have pulled an article from the New England Journal of Medicine. She's also a physician, about intermittent fasting. And it took a really deep dive into some of the science behind intermittent fasting, some of the clinical applications. And I was just hooked. I thought it was fascinating and I wanted to know more. And of course, if you start looking at physiology of fasting, you enter into the world of ketones and alternate fuel sources, which are not really alternate, but are another fuel source. And then I thought, wow, I wonder if a trial at a ketogenic diet might help me manage some of my low level anxiety and help with my cravings. And maybe it's a great way for me to just abstain from some of these foods that aren't really helping me and aren't really serving me. So I started on a ketogenic diet for myself. And I also started just absorbing a lot of information. And I listened to low carb MD podcasts, and I, heard about regenerative agriculture, and like it really took a lot of different directions. And it was fascinating to me. It was this whole world that I hadn't heard about before. And then I started hearing other physicians talking about the success they were having in treating their patients. And it was beyond just type 2 diabetes. I listened to Dr. Chris Palmer talk about crazy success he had had with some of his sickest mental illness patients. And I thought, wow, I wonder if maybe it isn't just for me. I wonder if it might be for my patients. And that was sort of a passing thought while I was in fellowship. I didn't have a lot of control over, what we were doing, and I was still drinking from a fire hose, just trying to learn the surgical side of my field. But then as I got into practice, I moved from Minnesota up to Northern California, and I was working in the Sacramento area for a number of years. And I worked for a multi-specialty organization that really prided itself on primary care and prevention. And the only problem with that was that as the vascular surgery group, we did all of the amputations for that multi-specialty group. So whether they had vascular disease or not, we would do all the amputations for any patient in the group. And so that included patients with diabetic foot wounds with fulminant infection or sort of limb threatening levels of infection, and a few other things. But the diabetic foot ulcers was a real eye opener for me because I would ask these patients what they had been told about managing their diabetes. And they said, oh, the dietitian said I could eat whatever I wanted. I just had to inject more insulin. And I kept seeing these patients with a hemoglobin A1C of 12, 14. And I thought, these are our this is our billboard for primary care and prevention. Like, what are we doing? And I'm having to remove body parts from these patients. And I know that Dr. Gary Fettke, he's one of the pioneers in the therapeutic carbohydrate reduction space. As an orthopedic surgeon, had a very similar experience doing these amputations that he came to realize were preventable. And then I kept doing these amputations that I thought at this point I knew, in fact, were largely preventable. And then all my vascular patients with bits falling off of them because they don't have blood supply anymore. And by the time you have such bad circulation in your legs that you have severe pain in your foot at night, or you have wounds or ulcers that aren't healing, the mortality of that level of disease is like stage 4 cancer. It's like a 50% mortality at 5 years. And I just couldn't quite stomach the fact that I was doing these hugely morbid operations for patients, and there was no conversation about prevention, right? Nobody had ever told them that this was a preventable or at least treatable disease if we had gotten to it 10 years ago or 15 years ago or 20 years ago. And what would be possible if we just paid attention much earlier in the process? Now, don't get me wrong, I enjoy some surgery that I do, but when you have patients that have strokes or heart attacks as the complications of these procedures of their disease, you start wondering, like, isn't there a better way? And I had listened to enough other pioneers in this field to actually really believe that yes, actually there is a better way. And that's how I got started about in sort of the preventive space, and it's been hugely rewarding. It's actually truly my passion. I don't think I ever knew that going in. I really thought that the surgical side was what I was destined for. And now I'm quite sure that, in fact, the prevention space is absolutely my calling.
Yeah. Yeah, for sure. I can remember, I'm a primary care doctor, but from a primary care standpoint, I mean, I used to practice very traditionally for years and years. And then when I kind of discovered all this and that I could actually reverse things and reverse type 2 diabetes, I mean, a lot of my listeners have heard my story, but it truly gave me like a renewed passion for medicine. And I mean, I haven't slowed down since. Like I love what I do, and being able to help people. Whereas before, I just, I was just giving out medicines and not really fulfilled. And now I'm truly fulfilled. So that's really cool. So I'm wondering, kind of on your personal journey as you're discovering all this, and you're learning about, eating meat and butter and higher fat, which obviously goes against what we've always been taught. And even for lay people, sometimes that's a hard hurdle to cross. But you're a vascular surgeon, and so, like, what was that like in your mind? I mean, were you like, oh my gosh, like, I mean, this stuff is just going to build up in my artery, because that's kind of what we've been taught. I mean, was that a hard hurdle for you to get over?
Well, I think as part of my educational journey, that was obviously a question that had been raised in my mind was, what is, as great as this might be for psychiatric illness, for endocrine illness like type 2 diabetes, like what is the impact of this for my disease process, for the cardiovascular disease? And it turns out there are a huge number of very bright people who have looked into this, right? And Nina Teicholz, Gary Taubes, like there are huge swath of information that are available that will remind you that we have known for quite some time, decades, that saturated fat is not quite the culprit that it's made out to be, and we shouldn't blame the meat for what the potatoes did, to coin a phrase, um, or to borrow one from others. But it's also true that every person responds differently to these nutritional interventions, and I find myself kind of in the in between space where the very hardcore low carb community is really anti medication for lipid lowering. And of course, my very traditional allopathic surgical side is very pro lipid lowering medication at high intensity because we have evidence that in that patient population with severe disease, it reduces all cause mortality and inflammation and cardiovascular events. And I find myself in between place where I make everybody unhappy um, because I really have to look at each individual patient and say, a ketogenic diet or therapeutic carbohydrate reduction or whatever you want, a Mediterranean, high fat Mediterranean, low glycemic approach. I mean, you can use whatever buzzword you want, but everybody's lipids respond differently. Some people really do get a significant escalation or elevation in their apolipoprotein B or their LDL-C or their LDL particle count. And we can talk about, what I think are better metrics for cardiovascular risk, but not everybody. And a lot of people get significant reduction in triglycerides and a significant improvement in their HDL. And they are able to come off their blood pressure medications because they reduce their insulin. And, you get a huge benefit. And if there is a small consequence in the ApoB, but we fixed three other things, let's talk about it and decide whether we need to treat it or not. And we don't always, right? It's, people who come to me with minimal disease, I don't put everybody on lipid lowering medication, even if their ApoB bumps a little, but I do like to track what's going on in their vessels, right? And we can use imaging, we can use some advanced laboratory testing and try to get a gestalt, but it's an individualized thing. I don't really have a one size fits all approach to that. And if cholesterol were truly the only bugaboo for cardiovascular disease, we would have cured it years ago. We've been giving people statins for ages, and we have not really made a considerable dent in that disease process. Now, yes, to some of those medications I just said, they've reduced all-cause mortality, but not by a huge amount, right? It's not like we eliminate all that residual risk. There is still a significant amount of residual risk, and some of that comes from oxidative stress. What causes oxidative stress? Too much glucose, too many inflammatory fatty acids, right? And so we have to sort of take the whole broad picture into account. And I think this is one of the reasons that metabolic health is such a niche thing, is because it really crosses a huge number of disciplines, right? When I have a patient who comes to see me, it's a little bit of endocrinology and it's a little bit of cardiovascular medicine and it's a little bit of primary care. And, it combines all these things. And so nobody really owns that. And everybody, in the very traditional medical model, is rewarded for staying in their silo and just, really specializing and doing their niche and doing it well. And if you have, an A1C problem, well, then you get a referral to endocrinology. And if you have an inflammation problem, then you get referred to rheumatology. And if you have a lipid problem, you get referred to cardiology. And then, in an ideal world, all those specialists would talk and collaborate and come up with a unified treatment approach. But in truth, that's not really what happens, as we know. And so if you're going to be in this space, I think you end up having to do a lot of sort of personally directed education and figuring out, where can you expand your knowledge base and practice comfortably within a reasonable scope of practice. And what are you going to have to, I don't take care of every cardiac issue, right? I will refer arrhythmias out, and I will refer out people with such severe disease that they might need a cardiac cath, because I don't do that. But up to a point, I take a fair amount of ownership of these different issues, at least in my metabolic practice.
Yeah. I think that's fantastic. Kind of one of my pet peeves is, again, I'm in the primary care world, but that more primary care doctors don't do that, because I feel like, in primary care, you should be able, obviously we can't do surgery, but I mean, we should be able to coach them about how to get metabolically healthy, and we should be able to handle their diabetes in most cases and not have to refer to an endocrinology. And they don't, many times they don't need five different specialists. So anyway, that always kind of has aggravated me. I'm curious what your colleagues, kind of think with you talking about, keto and metabolic health and all this stuff.
Again, it depends on which colleagues. There are certainly people in the um, allopathic space, especially in the cardiovascular space, who still truly believe that saturated fat is the devil and that everybody should have sort of an Esselstyn-based, very low fat, very plant heavy approach. And there is some data for that. There are some data for that. I find that it's a little myopic, right? It will reduce your ApoB, your LDL-C, but not everybody can do it in a way that doesn't elevate their insulin and doesn't elevate their glucose. And then we run into vitamin deficiencies, and then we run into inadequate protein intake sometimes. And so, you can use whatever label you want for your nutritional approach. There are some people who really benefit from true ketosis. There are other people who benefit from severe carbohydrate reduction without necessarily being always in ketosis. And then there are people who do fine on sort of a modest carbohydrate, which I would define as 150 grams a day or less amount of carbohydrate reduction, and can maintain good metabolic health under those conditions. And again, everybody's different, right? If you are metabolically unwell and have been for decades, your threshold's going to be different. If you have some comorbid conditions, severe psychiatric illness, severe inflammatory illness, severe addictive food addiction issues, right? You're going to do better from a true ketogenic diet. And we still may have to manage some of the downstream consequences if, in fact, it does alter your lipids, right? Maybe that's a problem for you. Maybe it's not. We have to see. But everybody gets to have their own kind of tailored approach depending on what's going on with them. And, I like to be data driven. We can try one approach for a while, then we recheck labs and we see how you're feeling. And if we need to be more restrictive, great. And if we can be less restrictive, or you find that your athletic performance is not what you want it to be and you need to re-add some carbohydrates in a targeted fashion to do that, great. Let's talk about it. Let's try it. I mean, one of the beautiful things about preventive metabolic care is that we have time. We have the ability to iterate these little experiments at 3-month, 6-month, even 12-month intervals, right? I'll have people who say, I refuse to be on medications. I want to see what happens if I try lifestyle alone for a while. Great, let's do it. And I'll recheck your carotid intimal medial thickness in a year and we'll see where we are. If we're stable, then it's working. If we're not stable, then we can talk about what to do differently. And for a lot of people who are, again, looking at primary or even primordial prevention, who've never had a heart attack, don't have severe plaque in the arteries that we can see, that's a very reasonable approach. And it really empowers patients to take charge of their own health and their own life, right? I can't make anybody do anything. They have to choose. And whatever they want to do, they will find so much more success doing a plan that means something to them, that they have bought into because they made it. And in terms of, what helps people achieve these lasting changes, it's them, right? I provide good information to help them achieve success, but I can't drive those changes. People do that intrinsically.
Mm-hmm. Yeah. I want to talk a little bit more about prevention. You've talked a little bit about it, but to my knowledge, and you can verify this, I believe cardiovascular disease is still the number one killer in America. And so how would you advise somebody from, your perspective as a vascular surgeon to just prevent, cardiovascular disease altogether? So, I mean, I'm a pretty healthy guy. So you have a healthy person, low risk. What would you advise them to do to not have to come see you, at least from the surgical standpoint? I mean, what are your kind of big tips to just prevent cardiovascular disease?
It really comes down to the drivers overall for developing plaque, right? And what are those? Well, metabolic syndrome, insulin resistance, the sequelae of that, that's the first one. So get that under control. The second one tends to be inflammation, and that comes from a lot of different places. But we see it in patients with autoimmune disease. We see it in people with periodontal disease or significant dental health issues. But having some idea of whether you have ongoing low-level inflammation in your body is an important thing. It can be from visceral adipose tissue. So if you are have excess body fat and especially excess visceral adipose tissue, that causes low level inflammation. So measuring that and addressing that and finding that root cause, because treating the number has been modestly successful in clinical trials, but it tends to come with other downstream consequences like increases in infections. So if we just treat inflammation with an anti-inflammatory approach without understanding where it comes from, that's less successful than really getting to the root cause of that. High blood pressure, right? That goes part and parcel with metabolic syndrome most of the time, but not always. There are still people who require additional management for hypertension. That's probably the one that goes silently unaddressed or undertreated for a vast swath of the population that could be much more simply managed. And toxic exposures, right? Nicotine and tobacco is still a thing. Vaping is maybe better than cigarettes for lung health. It's not clear that nicotine, whether it comes in a pouch or whether it comes in a vape or whether it comes in a cigarette, is any better for your blood vessels. So toxic exposures, I mean, I don't know that we can do anything about the microplastics. We don't even know truly what our biggest exposure is, but having some awareness that our environment is a little bit toxic and doing what we can within our means and within our environment to try to mitigate that as best we can is reasonable. And then just paying attention, right? Understanding that there are ways to monitor your vascular health long before you have pain when you walk, long before you have a mini stroke, long before you have chest pain. We can address these things, and they're not recommended, so they're not often covered by insurance. But if you are invested in not dying of the leading cause of death in this country, and it absolutely still is cardiovascular disease for men and women, then it would behoove you to get some advanced imaging. Now, that can be a coronary calcium scan. That's the most accessible. It's my least favorite of the three that I'm going to give you, but it's good enough for most people most of the time. It's not wonderful in really young patients, but we'll talk about that in a second. The other two that can assess both calcified and soft plaque would be an ultrasound called the carotid intimal medial thickness scan, or a CIMT, done at a very high quality lab, or a coronary angiogram, CCTA, that now is available with something called a Clearly overlay, which is an AI-based overlay that really gets into the weeds about what kind of plaque you have, characterizing whether that's soft or calcified plaque, giving you plaque volumes, the distribution in the different arteries. It's a wonderful tool. It's just expensive and a little more invasive in terms of a dye load and then the radiation exposure. But for higher risk people, it's a great study, and I love it. So those are all things that I have used in my practice to help people get a better sense for their risk when we can make small changes to create big shifts in long-term risk and outcomes, right? By the time you get to me with pain with walking or mini strokes, we kind of have to pull out the big guns and, give high dose meds and do surgery or do, more invasive things. If we get you 20 years, 30 years, 40 years before we get there, then we can make small tweaks and the changes don't feel so overwhelming and they don't feel as hard. And then we get the benefit of that integrated, area under the curve over time, over decades. So it's small changes that start early, I think, is really the way to go. And you have to find a provider who's willing to sort of look at some of these things with you. And, we now benefit from Dr. Peter Attia's book, Outlive, and all of the, wellness and health and longevity physicians and scientists who are in the space who are talking about this and talking about finding somebody who can help you understand your lifetime risk even before you're 40, and then you can finally be on the calculator, right? So I'm talking about the American College of Cardiology risk calculator, which won't give you a 10-year risk until you hit age 40, because age is one of the biggest risk factors. But what if you have, what if you were a woman with a high-risk pregnancy and preeclampsia and migraine with aura and rheumatoid arthritis or lupus? So you're super inflamed and you've had all these high-risk features and you have a history of premature coronary disease in your family. And maybe you have something called LP little a, lipoprotein little a, so a genetic dyslipidemia that will predispose you to early plaque and valve problems. If you have all these things, you can know that at age 35, age 38, and you can mitigate that risk. Why would you wait until you're 40 and then get a 10-year risk calculator, and then somebody, slaps a statin on you and says, good luck. That's
Mhm.
not, I don't think that's it. I don't think that's the right way.
Yeah, yeah. Talk a little bit more, if you will, about the coronary artery calcium score, because that is something I typically recommend as just for a couple of reasons. One is just gives a little bit of information, a good starting point if they've done nothing else. Number two, at least here in Oklahoma, it's very cheap. They can get one here for $50 cash, and I feel like for $50, it's just you can get some information of it, and especially if it's a really low score. But what's your thought on those?
I think it's absolutely better than nothing. And if that's what's accessible and easy to get, do it. Where we run into trouble is with younger patients, right? If you are, a woman under 50 or a man under 40, and you have a negative calcium score, that is nice, but it may be falsely reassuring. You may have some soft plaque that has not yet calcified. Calcification is sort of the body's attempt to wall off or seal off that inflammatory plaque in the arterial wall. And that may not have happened yet. And it doesn't mean you don't have disease. It just means that we can't see it yet with a calcium scan. And if you're 40 and you have a score under 100, most people would say, oh, that's fine. It's low risk of an event in 10 years. Well, that's fine. But we're talking about lifetime risk. If you're 40 and you have calcium on your CAC, I'm going to be pretty aggressive. I think that's concerning. That to me is early disease, because that means you had plaque in your 30s that's now calcified at 40. So I'm going to take a more aggressive approach, even though most people would say, well, if the score is low, it's not so bad. But understand that as a percentile of the population, somebody with a calcium score of 50 at age 40 has a higher score than I don't know what the percentile is off the top of my head, but call it, 80th percentile. They're worse than 80% of their peers with that score. If you have a calcium score of 50 at age 80, well, now you're in like the 10th percentile. Everybody else at age 80 has a higher score than you. And so at age 80, that score is so much more reassuring than it is if you're at age 40 with even a low score, right? If you have
Mhm.
calcium at 40, I'm going to say, all right, now is the time to buckle down and make some of these changes so that we don't wait until it's 300 by the time you're 60
Yeah.
and go from there. The other problem with the calcium scoring is that it's a little bit challenging to monitor treatment over time. The data writ large say that progression in coronary artery calcium represents progression of disease and increase in risk. In the preventive space, there are probably two things that are happening with people that get a significant jump in their coronary artery calcium. Some of that is absolutely progression of disease, and they are people for whom we did not appropriately manage their risk. But the other thing is that people who are well managed now have soft plaque that has stabilized and calcified. And there are people that dispute this, and I'm not going to say that this is a for sure thing, but you can kind of go either way. And so I like the methodologies that can measure either arterial thickness or measure the soft plaque, because that's really what we're trying to get at, is to reduce the chances of a thrombotic event or embolization from the soft, more vulnerable plaque. And that gives us a better idea, because I also use this to monitor my therapy over time, right? Yes, lab measures are nice, but they don't really say what's going on inside the vessels. So I try to use imaging longitudinally to measure the effectiveness of my therapy, right? Because some people will still form plaque with an apolipoprotein B at goal of 70. If they're still forming plaque with an ApoB of 70, that's no longer their goal. Now we're going to drive them down to 55 or less, right? Because they're still making plaque. Or they have other issues that we have not managed, right? Inflammation, oxidative stress from something else that's ongoing. But, we shouldn't rest comfortably because, well, all the numbers are in the box and we're doing fine. If you're still making plaque or your scores are getting worse, we're missing something. We should go back and try to figure out what's going on. So coronary calcium is a harder one to use. For that reason, the CCTA or the CIMT are perhaps better for that, at least in my practice, in my hands.
Okay. You mentioned that if somebody in their 40s is showing plaque buildup or signs of plaque buildup, you're going to be aggressive. What does that mean in your mind? Is being aggressive mean you're going to, medication management plus lifestyle? What does being aggressive look like?
Well, I think being aggressive means putting that fear in the patient. I don't want to scare people, but I do want to be real that like this is severe disease or has the makings of severe disease down the road. And we then, the first part of being aggressive means understanding where that risk comes from, right? Is this a genetic thing that came from a set of cards that your patient got from mom and dad that they had no control over? Fine, great, now we know, right? And what does that look like? ApoE4 allele, methylation defect, an MTHFR that causes elevated homocysteine, uric acid clearance problems and hyperuricemia. It could be familial hypercholesterolemia. Like all of these things can contribute. Again, autoimmune disease that's not been diagnosed, something of that nature. Terrible stress, chronic stress, and high patients who have a history of trauma or PTSD or high stress careers all can have sort of a prolonged inflammatory response that creates this issue. Substance abuse, right? People who think they can get away with heavy drinking or tobacco nicotine use, things like that, right? We don't have to go with meds, but we have to do something, right? And what that is depends on the patient, depends on what they're open to. And again, the nice part about prevention is we have time. So we get to ask patients, what do you think might be causing this? What do you think is something you're willing to change right now, right? Because if they're not willing to change it, then you're wasting your breath. Don't waste your time, don't waste your energy. But almost everybody, if they're coming to me in a preventive capacity, knows that there's something that they can do differently, and they're prepared to make those changes. That's why they walked in the door and paid good money out of their pocket to come see me and talk about this stuff.
Mm-hmm. Okay. What's your advice on exercise? You mentioned Dr. Peter Attia, and he's real big on exercise, and I've heard him say that like exercise and specifically like VO2 max is a predictor of like morbidity and mortality more than anything else. How do you talk to your patients about exercise, and kind of what do you recommend with that?
So I borrow sort of Dr. Atia's framework in a lot of ways, right? I tell people I think of exercise in 4 different buckets. We have the most nebulous one, which is sort of flexibility, coordination. That's yoga, dancing, stretching, mobility work, calisthenics, and martial arts, things like that. And that sort of fulfills a lot of the functional movement, anti-fragility piece. It also just helps you train for other things, right? If you're in sports or if you're training hard in the other buckets, then that work is useful to you. Mostly when I have older patients, I say it's what's going to allow you to catch yourself if you trip and stop you from falling. The other thing that will catch you from falling is strength. And the one that I am most bullish about for my patients is resistance training. I treat a lot of perimenopausal, postmenopausal women. Hormone therapy is part of this whole bucket of stuff that I do for people as part of cardiovascular risk reduction and prevention. By the way, it also dramatically improves quality of life for a lot of people. But I also think that being under-muscled, as Dr. Ati would say, is a huge risk, right? And we talk about grip strength. And I think grip strength is the same thing as VO2 max. It's not so much that it really matters that you can grip so that you can hold on to a handrail when you fall. It's that it's a marker of your overall strength and resistance type fitness. So resistance training is the next bucket. And if I had to give people anything to take home, especially from a metabolic health standpoint, it's the resistance training, right? And why is that? It's because the muscle mass is our biggest sink for glucose. And so when we have those GLUT4 transporters that are taking sugar out of our bloodstream, we are also using our muscles even when we're not training. And so for bone health, for general anti-fragility, for metabolic health, to dispose of glucose, muscle is our best friend. So I'm pretty bullish about that. And then the last 2 buckets are both cardiorespiratory fitness, right? We have sort of a low intensity, steady state cardiovascular training, which is what Atia and others would call zone 2. And then we have the high intensity sprint type workouts. And both of those are also excellent for longevity and overall cardiorespiratory fitness. And cardiorespiratory fitness is that VO2 max. And it's all important, right? We know that aerobic exercise improves our brain-derived neurotrophic factor. So if you have people who have anxiety, depression, concerns for dementia because they might have an ApoE4 allele, cardiovascular exercise is really important for brain health. We know that. I'm not sure if resistance training generates that same level of hormonal response, but we have to have something kind of in every bucket, I think, for optimal training. And everybody usually has one that they prefer and one that's a challenge for them. And so, I talk to patients about, can you stretch just a little bit in one of those other buckets that's harder for you? And
Hmm.
then we talk about making sure that training in the bucket that is your favorite is actually as efficient and effective as possible.
Hmm. Okay, yeah, I like it. So I'm curious if somebody has pretty advanced cardiovascular disease and they're coming to you and you're being a surgeon now and possibly even having to amputate a limb or something. Um, I would think most of your colleagues aren't going to talk to them about all these things that you're discussing now, but you start talking to them about, metabolic health and all these things. If they're in that advanced state, how much of that at that point is reversible by doing all these lifestyle changes that you're going to recommend, or at least is our best hope of halting the disease and any further disease progression? Or do you see that if patients really buy into what you're telling them, that a lot of that can actually be reversed?
It really depends on what's going on and how bad it is, right? If you come to me because you've had many strokes and you have more than a 50% narrowing in your carotid artery, all the lifestyle change in the world is probably not going to save you from me recommending a surgical intervention. But surgical interventions in my field are notoriously short-lived. You get what, 5 years on average out of a bypass, maybe. And so what I can promise is that your recovery from surgery will be better, whether it's that you stop smoking for 2 weeks or whether you've cut out your carbs and you are now more metabolically flexible. If you can decrease your glycemic load, wound healing will be better. Your chances of getting a surgical site infection are lower. Your chances of developing a pneumonia after surgery are lower, right? All of these things get phenomenally better, even if you still need that operation. And it will dramatically improve the patency or the durability of that repair that I do, which is never as good as what God gave us to begin with. So, whenever I do, whether it's a stent or a bypass or a clean out with a patch, we kind of start a clock, right? The clock starts ticking about when that's going to fail and we're going to have to try something else again the next time. That's always in the back of my mind is, okay, this is the first operation, but what's the second one? Because this won't last forever. And how long that lasts, how well we do in terms of kicking that can down the road and maybe never needing another intervention from me, that's really what we can dramatically improve by more exercise, less sugar, more sunlight, more meditation, less stress, all of these things.
Yeah, yeah, very nice. Well, tell us about Nexus Health Span. So that's kind of your wellness clinic. So just you've mentioned it a little bit, but tell us more about what you do there. And yeah.
Yeah, Nexus Healthspan was founded by my partner, Mr. Zachary Lott, who is a nurse practitioner who really is a pioneer in this space and developed this passion for treating metabolic unhealth or illness and heart attack and stroke prevention. And he early on realized that, again, we cross so many disciplines that part of our treatment plan is sometimes hormone therapy for patients who want and are open to that. Sometimes it's reversing their diabetes using nutrition and medication if necessary. And sometimes it's fixing their inflammation with an anti-inflammatory diet or supplements, right? We kind of cross all these different barriers. And I was lucky enough to meet Zach through a family friend and asked to, spend some time with him in his clinic because I thought what he was doing was really innovative and not something I had seen or even heard of very many other places. And after I had spent 2 days with him, I called him and I said, "Hey, I don't know how it's going to work, but I would love to come work with you and learn from you and try to build this out for myself because what you're doing is incredible." I mean, his patients were so happy with how they felt and how much more vigor and, joy they had in their lives because they just felt better, right? And
Mhm.
whether that's managing, diagnosing, and then helping them get treated for sleep apnea or, menopausal hormone therapy or their inflammation and chronic pain, right? We see people come to us for all kinds of different reasons. And it's all kind of related. So is it longevity? Maybe. Is it wellness? Sorta. Is it, um, just a supplement mill? No. But is it functional medicine? Sorta. Is it integrative? Sorta. Right. I don't
Hmm.
know what the label is, right? Because we
Hmm.
don't really do the same thing as very many other people. But whatever it
Hmm.
is, it seems to be working because our patients are happier and they feel better. And we are seeing great improvements in both their metrics and their imaging. So we hope that what we are doing is really moving the needle for these folks. But it's pretty unique.
Yeah. Yeah, I kind of describe what I do, which it sounds very similar, is wellness medicine. That's what I call it. And so it sounds like that's what you do is wellness medicine.
Yeah.
So I feel the same way. I don't know that even though there is a lot of overlap, I don't really fit in the functional, necessarily the functional medicine space. A lot of people, just because I'm not, quote, conventional, they'll call me alternative, which, I don't know what I think about that term, but I'm like, well, I'm not really alternative. But anyway, so yeah, I just say, well, I'm in the wellness space. That's kind of what I say. So, but
Yeah. Great.
um, so if I remember right, and I don't know if you can talk about this or not, but do I remember you saying you have a book coming out?
I do. I'm still in the process of
Can
getting some edits done, but I'm
can you give
hoping
us
that
any
I'm going to get
teasers
it.
on that or?
Yeah. So, I had, as I mentioned, I was in Northern California for a couple of years doing these amputations, becoming very dissatisfied with the primary care prevention side of our specialty, multi-specialty group. And then, my dad's health started to kind of teeter and take a little bit of a turn. And my mom and I had a real heart to heart. And she said, look, you've been there for 2 years. Your partnership election into that practice is at 3 years. If you're not going to stay there, maybe you should think about moving. Like, if that's not the practice for you, if that's not the place for you, if you're not happy there, then I could maybe use your help closer to home. And I thought, interesting. I hadn't really contemplated that, but it struck me as an opportunity. And, I thought about what I have given up in terms of my training and what it's cost me in terms of time with family, friends, loved ones, missed holidays, missed nights and weekend, like all those things that we defer as we go through our medical training. And I thought, I'm not necessarily going to have forever with my dad. And this is a chance to make a choice that really prioritizes my family, my connections with them, and the things that fill my cup, which is that's that connection, that human interaction.
Mhm.
And so I made the pretty challenging decision to leave my practice in Sacramento and move down here to San Diego. I didn't have a full-time job, so I started doing some locum tenens work. And this is about when I started thinking about starting a metabolic practice or the wellness practice. And it's basically been about a 2 year sabbatical. And during that time, I realized how much I had become disconnected from my family, my friends, my patients, the healing nature of what we all went into medicine to do. And I thought, somebody ought to write this down. And a friend of mine asked me as I was taking time off, he said, if you were going to write a book while you have more time, what would you write about? And this is what I came up with, right? This idea that we have kind of, as doctors, and maybe more broadly, everybody in the healthcare space has become progressively and systematically disconnected from the things that make us human. And is that really what is beneath this epidemic of burnout, which is a kind of a throwaway term at this point, but dissatisfaction that all of us feel coming out into the workplace, right? Our patients aren't getting better. We're suffering. And everybody is trying to understand, is it this job? Is it this place? Like, what is it about it that makes me unhappy? But I really think my hypothesis in the book is about it's that we have become really disconnected from our humanity. And especially in this healing profession, that is costing us dearly. It's costing us our job satisfaction. It's costing us our mental health. It's
Yeah.
costing our patients their success and recovery because pill pushing isn't it.
Hmm.
Um,
Yeah.
and yeah, that's what it's about.
Interesting. Do you have a title yet, or can you share that?
Called Disconnected.
There you go. All right. Well, very cool. Well, I may have to have you back on again when it comes out, and we'll talk about the book. So,
I'd love it.
all right. Well, very nice. Well, anything else you want to throw out there that I did not ask you?
No, I think we covered a lot of ground. Thank you.
Perfect. Well, as we wrap up here, I always ask my guest if they could give us one health tip that could make us healthier today. What would you say to that?
Go to bed half an hour earlier.
Okay. Yep. Sleep is important for sure. So,
Yeah, I think we didn't talk a lot about sleep, but I would say it's probably the most underrated aspect of health and wellness, and something that not everybody needs to go to bed half an hour earlier, but prioritize your sleep. Let's call it that.
yeah. Perfect. Okay. Well, very good. So, nexushealthspan.com, is that the best place people can kind of contact you, follow you, and that kind of
Yeah,
stuff?
that's the best place to find me. I'm also on LinkedIn if anybody needs to reach out directly.
Okay, perfect. Well, Dr. Lily Johnston, really appreciate your time and expertise, and certainly appreciate everyone listening. And we will talk to you next time.
Sounds great. Thank you, Greg. Have a good one.